We evaluated sex differences in the iSCAD Registry. This was an important publication from iSCAD this past year. And in terms of background, we wanted to share with you that 90% of SCAD cases, as we know, occur in females. The majority of these events occurring in middle-aged females. SCAD accounts for up to 40% of acute coronary syndrome in females less than 50 years old. But given the low incidence of SCAD in males, there are limited data regarding the characteristics of males who develop SCAD. So with that, we looked at our objectives and looking at sex differences in iSCAD involving baseline demographics, presenting characteristics, precipitating factors, angiographic findings, management strategies, cardiovascular outcomes, and discharge medications. And we really found that mean age didn't differ between the sexes. The mean age was about 50 years old for both male and females. There really were no difference in the sexes in terms of typical cardiovascular risk factors, such as smoking, diabetes, blood pressure, atherosclerosis. And looking at this further, we looked at triggers preceding SCAD. And in our cohort, which consisted of about 9% females, 6% males. We found that emotional stress was clearly a higher trigger in females, and physical stress was more common in male patients, both isometric exertion as well as aerobic exertion. And in terms of clinical history, we found that autoimmune conditions were more frequently seen in female patients, as well as systemic inflammatory disorders, fibromuscular dysplasia, migraines, and recreational substance use was more frequently seen in male patients. With regards to SCAD presentation, we found that chest discomfort was the most common presenting symptom in both males and females. But females more often presented with non-chest discomfort symptoms, including shortness of breath, nausea, vomiting. But there were no sex differences in the clinical presentation of SCAD in terms of STEMI or NSTEMI presentations, cardiogenic shock, ventricular arrhythmia, or cardiac arrest. With regards to in-hospital outcomes, we found that there was really no difference in terms of in-hospital major adverse cardiovascular events between sexes. No major sex difference in the finding of multivessel involvement, in-hospital recurrent heart attack, stroke, heart failure, or significant arrhythmias. We did demonstrate that there was some in-hospital differences in terms of duration of length of stay. We found that females had longer hospital stays, and even after excluding pregnancy-associated SCAD, this was the case. At discharge, we found that males were more likely to be prescribed dual antiplatelet therapy and also more commonly prescribed statin medications. So really, in conclusion, in this very large cohort of SCAD patients, the largest in the United States reported, we found that females were reported to have higher rates of emotional stress preceding their SCAD, while males were more often reporting physical stressors preceding their SCAD. Females had a higher rate of fibromuscular dysplasia, autoimmune conditions, migraines, and men had higher prevalence of recreational drug use. Although chest pain was the most common presenting symptom overall, in females were more likely to have non-chest pain symptoms at presentation. The age and baseline cardiovascular risk factors really did not differ between males and females, but the clinical presentation, coronary territory of involvement, management strategy, and in-hospital outcomes were similar. But hospital length of stay was longer in female patients. Males were more likely to be discharged on dual antiplatelet therapy and statins, despite no difference in baseline hyperlipidemia history, LDL levels, and no difference in the history of coronary and non-coronary atherosclerosis between the two groups. The study really illustrates important sex differences in the triggers, presentation of SCAD, length of stay, and discharge medications in patients with SCAD. It was the first study to report longer length of stay in females with SCAD, the first study to report higher rates of discharge on dual antiplatelet therapy and statins in males. And most importantly, this study reflects the findings of contemporary real-life medical practice in the treatment of SCAD in the U.S.